The CHADS-VASc schema has recently been introduced to complement the CHADS-2 score and improve the identification of atrial fibrillation patients at truly low risk for thromboembolism. Now in circulation, there is a study that tested the predictive ability of the CHADS-VASc, CHADS-2, and Van Wall-Raven risk stratification schemes in a cohort of lone AF patients with a 12-year follow-up. The researchers conducted a registry-based observational cohort study of about 350 patients initially diagnosed with lone AF. At baseline, all patients had the CHADS-2 and even Van Wall-Raven scores of 0, and 76% had a CHADS-2-VASc score of 0. The overall rate of ischemic stroke was 0.2 per 100 patient years, really low. In the multivariable analysis, CHADS-2-VASc score of 0 was significantly related to the absence of stroke. Only the CHADS-2-VASc score had a significant prediction ability. So what is the take-home message from all this? First, the CHADS-2-VASc score reliably identified the lone AF patients who were truly at low risk for thromboembolism and was the only tested risk stratification scheme with a significant predictive ability for thromboembolism among lone AF patients. Second, and importantly, in lone AF patients, the development of any structural heart disease was a risk factor for ischemic stroke during follow-up. This fact emphasizes the need for a more comprehensive stroke risk stratification of patients with baseline lone AF and presumably low stroke risk. Make sure your patient does not have structural heart disease. Third, this study shows that the proportion of those at truly low risk does not remain constant and decreases continuously over time, especially when using the CHADS-VASc score. In this study at follow-up, only 44% of patients retained a CHADS-VASc score of 0. Therefore, the stroke risk of an individual AF patient should be reassessed regularly, probably at least annually, even if at the beginning stroke risk was truly low. I'm Peter Block, and this is a CardioSource Heart Minute.